Good morning. I'm Margie Gordon-Shea, Chair of Healthy Cities, Healthy Women London, and it is my privilege and pleasure to welcome you this morning. Today marks the fourth in a series of conferences spearheaded by the University of Pennsylvania, recognizing the unique role that women have in positively affecting social change. Urban women experience challenges exacerbated by conditions such as overcrowding in the built environment, access to health care, and increased incidences of violence. Today's conversation will address ways we can support women in their unique role as consensus builders whose force can change the paradigm and improve health for their families and for all of us. In each city Penn has hosted these conferences, dialogues were initiated about local issues with local experts and participants. In London, we are fortunate to collaborate with The Lancet as a dynamic partner in our efforts. We are proud to have earned the Mayor of London's endorsement and are honored to have Dr. Helen Walters of the Greater London Authority and Ms. Jane Lemham of the Mayor's Office on Policing and Crime join us today. Healthy Cities, Healthy Women benefits as well from Professor Helen McCutcheon and the support of King's College London, Florence Nightingale School of Nursing and Midwifery. We're grateful for the sponsorship of Penn alums and the Penn Nursing Board Chair, Dean Kaler, as well as the dedicated work of the London HCHW Planning Committee, many of whom are present today. And in a truly American thing to do, I'm going to ask that the committee please stand. Please stand. Thank you. A personal thank you for all of your hard work, insights, and dedication. Today would not be possible without your unwavering support and energy. Our first guest is Dr. Horton, but he has been delayed and will speak later when he arrives. So I get to kick off this tremendous day of learning by introducing our first keynote, Dame Ruth Carnall. Dame Ruth has spent most of her professional career in healthcare and healthcare-related industries. She has a strong reputation for leadership development and the creation of high-performing teams. She is frequently asked to speak about her experience in the UK and abroad. It's my pleasure to introduce Dame Ruth Carnall.
Thank you. Good morning, ladies and gentlemen. And for those of you from other parts of the world, welcome to London. It's not raining today, but I know that those of you who came and tried to enjoy a weekend here may well have experienced one of our weakest features, the weather. I did say when I was invited to give this address, goodness me, I don't know very much about women other than obviously I am one. So I'm going to try to connect my experience in working in health and health services to your agenda, but you'll forgive me if it doesn't have the sort of technical knowledge that certainly my colleague Dr. Helen Walters, who will be speaking to you later on today, will have. But I hope, nevertheless, it's an interesting and helpful start to your conference. I wanted to begin by reading you a quote from a piece of work that Professor Lord Darzi of Denham produced in 2007 in his work called Healthcare for London, because for me, it captures what London's all about. So I'll read it to you. London is one of the greatest cities in the world, inhabited for over 2,000 years. It has a rich historical and architectural heritage, a city renowned for its vibrant artistic and creative output, as well as for being a hub of innovation and invention. It is a financial powerhouse rivaled only by New York. This greatness is the achievement of London's wonderfully diverse inhabitants. London is a cultural melting pot, its people drawn from every corner of the globe. These people and this city deserve the very best. They should not have to settle for anything less than world-class healthcare. So he wrote that in 2007, and that was towards the start of my time as Chief Executive in NHS London. And for me, that the sentiments in that quote were, as it were, what got me out of bed in the morning and got my team out of bed in the morning. It was a hugely motivating thought to have responsibility for healthcare in such a fantastic city. So diversity, such as described in that quote, bestows a huge richness on the life of this city and other similar world cities elsewhere. But as you all know, it also can harbour some shameful inequalities, and that is the case in this city. So 3 of our country's top deprived boroughs are in London. Half of the top 20 are in London, but also in just literally a couple of miles away, you can find some of the wealthiest boroughs in the country as well, sitting side by side. We have the highest proportion of younger women in London. We have the highest proportion of ethnic diversity, the highest proportion of non-English speaking people. Half of the country's TB happens in London. The highest rates of childhood obesity in London. Life expectancy varying between the low 70s in some of our boroughs and the high 80s in others. So I could tell you, I could give you a whole set of statistics about health and healthcare in London, and what they will illustrate is very, very wide variation, the extremes of good and bad. And that's what faces health planners and public service planners, actually, but I'm interested particularly in what it means for health service planning and delivery. We know for certain that deprived populations in London get some of the poorest access to what then turns out to be some of the poorest quality healthcare. And is it any surprise that this has a multiplier effect on their health and on the health of their families? London has a very high proportion of small-scale, single-handed and sometimes double-handed primary care practices, wholly inappropriate for delivering modern, preventive and primary and community care. And as a result of that, the population in those parts rely excessively on hospitals for their health care, which in terms of the continuity of care that women and their families, for example, need, or people with long-term conditions need, it's wholly inappropriate. They get episodes of care, they do not get continuity of care. And yet, those poor quality services sit next door to some of the world's greatest teaching hospitals, Great Ormond Street, Moorfields, University College London, Imperial College. These places are world famous, and yet they sit side by side with some of this extremely poor quality primary and community care. We know that women living in deprived urban settings suffer poorer health, and not only that, they are the principal carers for children and often for elderly relatives as well, especially in ethnic communities. We know that women from ethnic communities often suffer poorer health. They often have poor access to health services because they're not sensitive to their needs. And on top of that, they also get poor access to some of the other services that might benefit them, for example, exercise. There's some very interesting projects run on the back of the Olympics, which actually tried to get women from ethnic communities more actively into exercise. And when Helen's here later on today, she may be able to answer your questions about how we tried to exploit the benefits of the Olympics for the health of poorer communities. We know that urban environments pose additional stresses for women, domestic violence, environmental stresses, economic stresses, and we know that women who suffer mental health problems will also go on to suffer additional physical health problems, and their life expectancy can be reduced accordingly. 40% of our children in London live in poverty. When I was in NHS London, one of the most surprising days for me, and bear in mind that I had all the statistical information available to me at any point in time, I went to visit a hospital in Newham, which is an extremely deprived borough in London. And I was taken on a tour of the hospital. I went to the maternity department. And in the maternity department was extremely busy, really, really busy, as you might imagine, in a small local hospital of that type. And I commented on how busy it was on that morning. And the midwife in charge said, "This is our diabetic clinic." This is our maternity diabetic clinic. So this was not a standard maternity clinic. It was an extremely busy, full clinic held every week for pregnant women with diabetes. So she then went on to tell me about how they try to trace the families associated with those women to try to help prevent their children from becoming obese and becoming diabetic as a consequence of that. So even for me, in the privileged position that I was of having all the information available to me about the incidence of diseases such as diabetes, to actually see physically that whole maternity department full of women pregnant with diabetes was still a shock to somebody in my position. So that's just one example. Those are the sorts of things that we're trying to tackle. So how can we respond to the needs of deprived communities, to the needs of women with their children, and to the needs of those families more widely? Well, we know that complex health and social care needs require coordinated action and coordinated leadership. From healthcare commissioners, from healthcare providers, from local government, from the voluntary sector, and from the public sector, all working together. We need continuity. Services for people with poor access need to be made easy for people to access and provide them with continuity. We need to try to find ways to simplify the complexity that exists around health and social care provision, not just in cities such as London, but across the developed world. All of my working experience, as you heard, has been largely in the NHS, and obviously National Health Service is just one aspect of the care needed for deprived communities. Most recently, I was privileged to be the Chief Executive of NHS London for 7 years. The NHS has many achievements, in my opinion, to be proud of. It's universal. It's integrated in the sense that it covers primary, community, secondary and tertiary care, and most importantly it remains free at the point of consumption and delivered according to need. For my mother and father's generation, this was little short of a miracle. Their existence as children was often governed by fear and anxiety about becoming ill and their parents being unable to pay for healthcare, certainly for themselves and often for the children. To my children's generation, the NHS is a slow, cumbersome, bureaucratic, old-fashioned, impenetrable organisation that they hope never to have to really go anywhere near. They don't understand it. They find it completely strange that they can't send an email to the GP to get an appointment, that he won't text them when, they find it very, very strange. So just in the space of 2 generations, we've gone from something that was seen, and is still seen actually by my father, as an absolute miracle, as he sits and now is wholly recovered from his quintuple bypass that he had a couple of years ago. He thinks it's a miracle. My children think it's some sort of weird monolithic thing that doesn't respond to them in the way that they want. You'll have seen from to refer back to the Olympics, to the film on the Olympics that was part of the opening ceremony. You've seen it on television, how much the NHS is at the centre of all of our politics. I mean, it was quite entertaining for us who work in the NHS to see it sort of celebrated in that way. But for my 37 years in the NHS, it's always been at the centre of our political life. It's always a topic of discussion at elections, always generates polarised opinions. The consequence, though, of that high political profile is a series of upheavals, reorganisations, with a few years between them. So in my 37 years, there have been 9 major national reorganisations, all politically driven. So you can see how many years you're likely to have stability as a leader in the NHS. The most recent changes implemented at the end of March this year have, in my opinion, been the most far-reaching of any of those 9, and have had the most fragmenting consequences on the way in which the service is structured and managed. So that that, in my opinion, also has significant consequences for some of the sorts of people that we want to support and that you're worrying about and considering in your conference. So vulnerable communities, vulnerable people need continuity. They need coordination of leadership, and these reforms have created a huge amount of fragmentation. So I'll give you one set of numbers to illustrate that. Before the end of March, there were broadly 7 commissioning organisations in London, 7 payer organisations. There are now 74. And those 74 are meant to cost 50% less in terms of overhead costs. So it doesn't take much to see that that's simply not possible. You cannot create 74 organisations out of 7 and then expect it to cost 50% less. So if you think about the continuity that's been lost in those changes, the turmoil for people, people worrying about whether they have a job or not and where that job's going to be, and the relationships and networks that were built up over the preceding years have been to a large extent lost. I want to tell you very briefly about one of my proudest achievements actually in the NHS in London, and then illustrate why I think it would be difficult for that to be handled in the same way now. So stroke care in London and across the world actually is one of the biggest killers. So strokes are one of the biggest killers, the third biggest killer I think for the population in London. And 7 years ago we had extremely poor outcomes for stroke care. So patients used to be admitted to any one of 31 centres in London. If they had appropriate scans or saw a neurologist, it was largely luck rather than good judgment. In general, strokes happen much more in the outer ring around London and not in the centre, and yet the best provision for stroke care was in the centre of London. So all the best provision was where people don't have strokes, crudely, and all the places where people were having strokes in the outer reaches of London were served by very poor quality providers. So as a result of a hugely collaborative programme amongst every single part of London, senior clinicians from across London working together to develop a model of care for stroke care and trying to implement that for the entire population. The consequence of that was to reduce the number of centres to which strokes are admitted to 8. So everybody now in London is admitted with the symptoms of a stroke to one of 8 hyperacute stroke centres, from where they are discharged after 3 days to their local centre back nearer to their home. Hugely controversial at the time because it required closing some of the best performing centres and opening and developing some centres in places that had previously provided very poor quality care. So the results of that work are now seen and internationally benchmarked. So the average transport time to a hyperacute stroke centre for our entire population is 14 minutes, whereupon 24 hours a day, 365 days a year, people have access to the best possible diagnostic and then treatment, including neurosurgery if that's what's required. As a result, London has better services for stroke care than any other city in the world. There are individual hospitals in other parts of the world that have better outcomes than some individual hospitals in London. But for the entire 8 million population, there is no city in the world that can compare with that. So if you're going to have a stroke, this would be a good place to have one, so bear that in mind. Even more interesting is that an international study done in a collaborative way between University in Boston and University College London has demonstrated that not only is this substantially better outcomes for patients, it also saves money. So if you think about the economic climate around health services at the moment, a £30 billion productivity challenge in this country over the next 5 years, a programme of work that dramatically improves quality, saves literally hundreds of lives, and yet costs less money, is the sort of model that we should be taking forward. So do I think, given what's now happened with health services and the structural changes, that transformation would be possible? So it needed collaborative effort across a very wide geography and across a range of different organisations. It required stable clinical leadership and engagement with communities about how people would get access to services. And ultimately, it required authority to make some choices in favour of equity. rather than choices in favour of continuing to invest in the places that we've always invested in, which would have been the easy thing to do. And there's an urgent need to do the same in other spheres, of course, in primary care, in cancer care. Do I think it's possible to do that now? So my answer is I certainly hope so, but I think it would be extremely difficult, because that collaboration that existed amongst all of those partners is so much more difficult to deliver now that we've got this fragmentation that I described. So I'm a glass half full sort of person. So I don't want to finish my remarks on something that says it's all too difficult. I want to say that that's not what leaders should be doing. You know, we can look at the fragmentation that's been created politically around us and say it's just too difficult to take these big change programs forward now. But to me, that's not leadership behaviour. So what can we do? What can be done in the environment that we now find ourselves in? So, first of all, forming coalitions of the willing, I think, can still make a difference, And one of the features of London, which I think is a huge advantage, is that it has a natural coherence. So even the most locally driven politician will still say that they come from London, even if they're in the borough of Haringey or the borough of Hounslow or whatever, they're still from London, they still care about London. So London as a city creates a coherence, has a coherence about it, and I think that with a coalition of the willing we can exploit that. We can exploit the powers of the mayor in that regard. Not many cities in this country have got a mayor with the powers that our mayor has got. And he has set up a London Health Board, which brings together a whole range of partners in London under his personal leadership to try to tackle some of these really compelling health problems. And he's been very good at setting priorities. It would be possible with a board like that, for everybody to come along and say, oh, what about us, what about us, what about us? And he's been very good at trying to be really clear about a few very specific priorities. One of those is to tackle childhood obesity. Now, if we did nothing else for our population but tackled that, think how much of a benefit that would be to future generations. So one of his top priorities is to focus on that. You may have noticed yesterday, if you were around yesterday, that we announced the creation of a commission under his leadership to look at the resourcing for health services in London, the delivery of health services in London, and to champion London's fantastic life sciences sector. Now that is, some people, you'll read some cynical stuff in the media and so on that says, well, this is just another review, another investigation, it's all very tedious, we've had thousands of those before. To me, this is the means by which what has been fragmented around us can be drawn back together again in a way that he can use his political leadership to champion. So ideas that you've got about how that could be made more powerful, contributions that you might want to make to it will be very much welcomed. It's going to be led again by Lord Darcy, partly a reprise of work that he did before, partly to look at which things did we take forward, which things did we fail on, but a real opportunity, I think, to put political leadership at the back of some of the really important health issues in London. London's blessed, as I've said, with some world-class research, teaching, specialised service provision. I think we can use those institutions as absolute focal points for development. They should be challenged not to simply draw resources into them, into centres. They should be challenged to use the resources that they've got to the benefit of their wider community. After all, we have the world's population, on our doorstep. What better research material is there than that? And if they can bring the investment that they generate to bear on whole populations, rather than, as they more traditionally do, drag that investment into large centres, they can make a big difference. Indeed, by working together, they can look at the entire population of London. At a local level, I wouldn't be 100% critical of the reforms that we are working with now. So the creation of clinical commissioning groups and health and wellbeing boards, I think, has huge potential at a local level. Before I left my previous job, I went round and saw every clinical commissioning group in London, led by general practitioners. And one of the things that struck me on those visits was the power that can come from a group of people who live and work in the community and who live and work in that community for many years. So I'd help the GPs concerned prepare their sort of presentations that they had to do in order to be authorised. And one of the things that struck me listening to their presentations, many of them began with, my family have lived in this borough for 2 generations, I've been a GP in this borough for 25 years, you know, my children go to school here. I think there's huge power in that connection to communities, which people in jobs such as I had could never hope to acquire, couldn't have that connection to local communities. So I think there's a huge possibility for change to be taken forward within communities from clinical commissioning groups. Their weakness is their ability to work together. There is nothing that adequately draws them together, and that's where I think the mayor can fill what would otherwise be a vacuum. And finally, the empowerment point. I think empowering individual citizens, and in particular women. So one of the programs of work that I felt very sorry to leave, actually, was a program about the transparency of data about the quality of healthcare services and their accessibility. So big program of work undertaken to put data about the quality of primary care in particular into the public domain in a form that can be easily accessed and used by my children's generation, for example. So put on the internet, available to download, available to be manipulated through a series of apps. That was just the start of a program of work to try to put information about quality and access into the hands of consumers. And I think that's a trend, actually, a trend in health services. Now got a national director with responsibility for taking that work forward. So I have great hope that by putting data, warts and all, in my opinion, err on the side of putting the data out there, let people work with it and use it and criticise it if it's wrong, it will become much more accurate through them doing that. I think is a real trend to focus on. So I think there are things that we can do. I would not, as a leader, stand here and say, this is all terrible, it's all not working, and all the wonderful things we used to be able to do can't be done anymore. I think there genuinely are some opportunities in this reformed setup that we've got to make change. I think it's important to make the assumption that these reorganisations that we have will continue. So in my career, there have been 9. Why would there not be a 10th? You know, is it sensible to think, well, you know, there's been 9, that must be the end of it. Let's hope that it doesn't happen again. No, I think we should make the assumption that these reorganisations will continue to happen. For some reason, each round of politicians thinks that they've got a better idea about how to structure it. And I'm sure that the next lot will have an even better idea about how to structure it. So we have to assume that that will carry on. We have to assume that complexity is a feature of the way in which these organisations are established, and as leaders we have to find ways to cut through that. We could use both of those 2 features, constant reorganisation and complexity, as excuses for not doing anything, as excuses for inaction, but that to me is not leadership behaviour. So what do leaders do? Well, first of all, they set out a really clear and compelling case for change that people can believe in. They set out a case for change, as Lord Darcy did in 2007, actually, and I hope he'll continue to do in his new work, that compels people to take action and condemns them if they don't. So to me, a case for change isn't a set of statistics, it's a compelling argument that has real emotional resonance for people, such as the words that I read out at the beginning. Leaders would bravely put evidence into the public domain about the things that are bad as well as the things that are good. Clinical and other leaders who are connected to their communities will take responsibility for trying to provide services, trying to commission services that are sensitive to those communities' needs. And we would be rigid. I use that word cautiously, but rigid about priorities. There is no point in dissipating your effort over every single thing that everybody tells you is important. It's really critical, I think, to focus on a small number of priorities and really try to take those through to the end. We did that with stroke care in London. I'm hoping that the Mayor will try and do the same with the much more complex challenge of childhood obesity. And with those things in place, those things that I've just cited, very, very few politicians are going to stand in the way of change built on those principles. And some, like, for example, our Mayor, may be prepared not just to, as it were, not stand in the way, but actually to back it and put their heads above the parapet. And that's what he did yesterday in announcing this Health Commission. I'm hoping to see that through with him over the next year, and hoping to see some things genuinely championed as part of that and genuinely brought together in a collaborative fashion. So I'd be fascinated to hear your views on that. I hope that some of you will feel able to make a contribution to that commission and see benefit from that flow through for women and their families in London. Thanks very much for listening to me. I'm very happy to take questions. Thank you.